Welcome to the Formfast webinar seminar featuring Forrester Research. My name is Laura DeVries, and I am the host for today's session. I would like to welcome you as we learn and discuss banking on EMR, too much for most, migration and coexistence in the EMR journey. It is my pleasure to introduce today's guest speakers. Craig LeClaire is the Principal Analyst at Forrester Research. Craig serves both business process and application professionals. He's a leading expert on information management and enterprise content management with a specific focus on electronic forms and document-centric BPM. He also provides guidance on financial services and content-related issues. Craig brings a wealth of experience and knowledge to Forrester throughout his 20 years' experience in IT and enterprise content. Craig earned a BS in economics from Georgetown University and an MBA from George Washington University. Scott Fuller will also be joining us today. Scott is a former IT director for Doctors Hospital Renaissance in Texas. In his tenure, the hospital grew from 83 to over 503 beds as he utilized workflow automation to automate applications to create a truly high-performance hospital. Scott is also a well-known author, a former corporation president, and a philanthropist. Scott is currently working on his 12th book entitled Creating the High-Performance Hospital and serving in a consulting capacity on hospital business intelligence for FastFlow by Formfast and is currently the Director of Workflow Engineering for Formfast. At this time, I would like to turn it over to Craig from Forrester Research.
Well, thank you. That was a very, very nice introduction, and good morning, everyone. Let me try to punch up the slides here for today, and hopefully we'll get some good Q&A going after the session. But we are, or at least I am from Forrester Research, and I do focus on medical records and information management as it relates to that industry. So there's a good bit of content here, and I'm going to try to go slowly enough to allow it to be absorbed, but it'll probably seem pretty quick to many of you on the phone. Firstly, just an overview of our recent medical information management research. Then get very much into the providers' content and collaboration challenges. And we have developed a maturity model because of the diversity in the provider area to reflect the growth and movement from more paper-based medical care to where the industry is going. And then we'll take a look at the all-important trends that will shape the future of the industry. So, don't need to belabor this point. We all know that the administrative area in healthcare is a huge opportunity to streamline costs. And in fact, the stimulus, the high-tech proposal from this current administration really focused on meaningful use and the development of a more digital approach to administration, focusing on this very strong amount that you see on this slide. Now, the research we're currently doing is titled Banking on EMR, Too Much for Many, and this doesn't reflect an indictment of the capabilities for EMR for that structured repository support for medical records. That's, as you'll see in the maturity model, that is the direction and where ultimately we will need to go. The point of this research, what we're finding in the research, is that there's a strong need to have a hybrid model and migrate and coexist during that EMR journey. And a lot of the technologies and processes I'll talk about really are focused on how do you do that. To obtain this information, we've interviewed 20 provider organizations, including community-based hospitals and teaching hospitals. And one of the reasons we believe the maturity model is important is because each of these organizations, small, medium, and large, specialty hospitals, are all going to proceed along a growth and maturity path that's quite different based on the inherent capabilities and their mission. We also talked with the Chime organization, which is a well-known group of CIOs, chief information officers of hospitals, to go over this material and to get additional insight. And, of course, the provider community is very important in providing the underlying technology to support this transition. So we talked with IBM, HP, EDS, some of the more document-centric providers like Iron Mountain, HCL, some of the enterprise content management providers, such as Highland Software, Laserfiche, and of course Formfast, who provides the unique set of form solution for hospitals around the world. So with that, let me dive in. With any research that we undertake, you always have to outline in your research plan the kind of questions that you'll want to answer. Oftentimes during the research, you'll adjust that as you learn additional things. But these were the some of the questions. What specific benefits from enterprise content management, that's what ECM means, have been achieved by providers in looking at this journey. A lot of the questions we get via inquiry, which is something that an analyst firm like Forrester does, we take, I probably personally answer 100 calls, 30-minute calls a quarter, and a lot of the, when a lot of the inquiries concern basics of OCR and scan, barcode technology, then when we do research, we want to try to uncover that. So we use the inquiry pipeline to really guide our research. In terms of the interaction with medical records, there are different approaches. There's more of a form-centric, which is a sort of minor leap from paper, so electronic form that looks like the paper, or there's more of a data-centric model where you come up with new, innovative navigation for the provider's interaction with these information systems. So we looked at the pros and cons of those. How can we help with adoption? What are the workflow processes that are important? What about paper forms, static paper forms? How important it is to get rid of them? How important is it relative to the 3 phases of the maturity model? Where is barcode technology really going? Then, of course, you have the clinical images, the DICOM images, so-called, that are associated with PACS systems. Many organizations on the technology side are wrestling with, whether to just have the PACS systems manage in a siloed fashion those images, or whether to create a central vendor-neutral solution, or just leave them where they are and use the emerging federated search, federated access, which we'll talk about, and ultimately what are the trends that are important. So let me talk about the maturity model now and give a sense of that. And the reason we have a maturity model is because EMR is really in its infancy in terms of its adoption rate in the industry. While there's positive results from places like the Veterans Administration and huge organizations like Kaiser Permanente, that EMR has a very positive ROI, reduces costs significantly. I think most of the industry would argue that that is the ultimate step in maturity. Yet, the overall adoption rates, and our research shows, is still quite low. And it can be low as 4% when you include the external physicians that are not part of large integrated service providers. So there's a problem there. There's a gap there, and that's what really we wanted to address in terms of this research. The issues, EMRs have a structured approach. They structured in terms of being data-centric. They do not deal well with the unstructured content, the supplementary paper charts, patient information, diagnosis and prescription information. So there's a focus there that is too narrow to support the overall sort of federated view of information required. Things like handwritten clinical charts, expensive to store and retrieve. And in this world today, there's very poor support for physicians actually understanding all the information that's relevant about a patient. 27% of patient charts aren't available for patient appointments. So there's issues. So EMR, while having a lot of strong future potential and current potential, it's just not going to solve the paper problem anytime soon. So ultimately, the elimination of lost charts, unreadable handwritten notes, particularly in areas like psychiatry, that handwritten notes are very, very important. Those are not absorbed well by the EMR environment. EMR cannot eliminate paper on its own. And with all the movement around HIPAA and meaningful use, and there's a growing need, I'm on the last bullet here, for these personal records to be provided to the person receiving the care. So there's a lot of pending momentum to have the record be more transportable. You know about health information exchanges that are hoping to do that. You hear about Google and others coming into the market to manage those personal records. There are requirements specifically in HIPAA that you will be able to take your records with you in a more portable way. All these things are putting pressure on the information management needs of provider organizations. And we think there's some hope in some of the technologies I'll talk about in terms of trying to solve that. Now, enterprise applications, and I'm putting EMR in that context, have issues in all industries. They are perceived as being high cost. There's often the organization is pushed to adapt their business processes to the particular capabilities of the packaged application. And the traditional packaged applications, just for completeness, in addition to EMR, but ERP and customer relationship management, they all have very similar characteristics. So I'm going to try to put that EMR in the context of those. But the idea of an organization changing its processes to match the applications, that mismatch is a real pain point. 80% of those surveyed cited that in this particular study. Inflexibility. So it's expensive to make changes in some of the packaged applications, and EMR is the same way. So changing those environments to be more adaptive to the organization is difficult. Poor cross-functional processes. And when we look at some of the technologies like workflow, business process management, they're really driving at that need to look at the full end-to-end process, and I'll explain that in more detail. The EMR really has a more dedicated focus to a very specific department or clinic activity and doesn't do well for processes like admission that need to cross processes. Lack of visibility. So basically, these are the problems that we found that are very consistent with the EMR environment. In general, we make a distinction between EMR and ERP and CRM as these packaged environments that I just talked about, and talk about the untamed business processes. That's a research theme that Forrester has about the end-to-end process that crosses different silos of different ERP instances and is really trying to address the entire spectrum. The differences among them are the packaged apps, and EMR is the example here. Structured data, in-band, a single process focus, very well structured, and has a strong IT focus. So they're sort of dedicated organizations in IT built around the EMR. Again, the people are supposed to adapt to the best practices incorporated in those environments. That's usually a difficult thing to do. Untamed processes, by contrast, deal with the unstructured content. By that I mean paper and all the things we're talking about, email, faxes, semi-structured content as well, like an Excel spreadsheet that may be relevant. Out of band, chaotic. So they're dealing more with more of the human element, more human decision-making, cross-department, and a lot of non-value-added activity. Don't have a specific number for that. Of that $150 billion in administrative costs, I'd say 30–40% of that is related to non-value-added activity, such as data entry, searching for paper, looking for missed documents, not having kind of an electronic folder environment that has an intelligence about what's needed to be in that folder and can automatically send out emails to collect it so it sits there. Cross-process coordination. These are the elements that we believe, based on our research, that are driving costs in that administrative area. So the technologies that I'll be talking about are really gaining momentum for providing that agility and that cross-process capability that is missing in the package or the EMR environment on the left. So the trend is to take the elements that change frequently, that are expensive in that environment, and to move them to this more agile set of content and collaboration type technologies. And some of these are external business rule engines that allow you to implement rules in an environment that can be changed more easily, more flexibly. business intelligence that allows you to analyze the data and have that be more flexible, having it be done not by IT but by a statistician who may be looking at trends in meaningful use that look at results-based analysis. So you may have some capability in the EMR to do that type of analysis, but what if your results that you're looking for cross not only that EMR instance, but another EMR in another department, or in fact the department that doesn't have an EMR. So this is where a more horizontal and more generic capabilities are very important. Business process management, BPM, one of the hottest markets that Forrester covers. That is using flexible tools to design work processes, to have them changed on the business side, to focus on analytics around simulation, to be able to model a process, use standards so that you can incorporate sort of round-trip data from empirical data from systems to be able to run it through simulators and understand how to continuously improve the process. A lot of organizations in the provider area are building centers of competency around business process management, so that's an important area. Document output management, this is the ability to create communications externally with patients and electronic forms. That whole area is one that has tremendous potential in this area. So I'm going to get into the maturity model here, and I want to say at the outset that there's the dominant model, maturity model in healthcare is the HIMSS model, and this is in no way meant to replace that. HIMSS looks at all of the technology in a hospital, from PCOE to EMR to full-blown diagnostic type of systems. This maturity is really related to the content and the patient records itself. So it's much more narrow in its scope. And it's looking at really the transition from unstructured content that really runs an organization, in this case phase one, which you see depends on paper and image-based patient records, and how that moves through two other levels to get to a full support of the needs of where we're going. So I wanted to keep that clear that HIMSS is the broader and frankly more accepted and pervasive model in the industry. So here you see a large green bubble physical chart. So in phase one, the size of that bubble is relevant. This hospital really has primary record is the physical chart. It may be for historical purposes on microfilm. Retrieval is not integrated with EMR and clinical systems, so you see a relatively small EMR bubble there. They're not really ready for EMR. There's so many organizations, 60% we believe, that are at this phase because of the strong and high investments required for EMR. So they're going to be in this place for a while. The DICOM images are in separate repositories. From a content features standpoint, there's some basic scanning of medical records, maybe in selected areas. There's a lot of dependence on static forms, core admin systems, records management, which is ability to put policy around content. So records management is a big deal. There have been a lot of legislation over the past 4 or 5 years that have driven the records management industry. So the idea of being able to lock down and gather information for litigation, for example, is very important. So you want to have policy around your content so that you can dispose of it under policy and actually reduce your exposure to litigation, so that you can lock it down under court law, under the Federal Rules of Civil Procedure, which says you have to do that if there is pending litigation. So content features are important. They're not really in existence in phase one. Very poor interoperability, as you might expect, and planning and strategy, really point solutions with no strategy for lifecycle enterprise content management. Unfortunately, that's where a lot of, we believe 60% of organizations are today. So to get to the next phase from phase one, the report we're doing will look at scanning and imaging. There's a lot of providers we spoke with that are really only doing go-forward scanning. and maybe going to the back file to get information for patients that come in, for active patients. However, there is an ROI for back file scanning. There are providers that will help you look at that, and some organizations have adopted that. They've started with the go-forward scanning and active patient strategy, but then once they got things set up, they had time and just started to rip through the old back file, and it was gone in 6 months. It's important to focus on that area to get to the next level in maturity. And here are some techniques for weaning caregivers off paper, migrating from that form-centric approach to more of a data-centric approach in later phases. Doctors, particularly of a certain demographic, much more at ease with moving from the electronic form with checkoff boxes to something that looks like that on the screen. Others, may like new, more innovative navigation, but it looks like the form-centric model is a strong one right now. Deficiency reports, getting that sign-off for deficiency reports done via email and workflow is a good way to jumpstart digital adoption. So these are just some tips, really, to do that. Now, phase 2 is the ultimate hybrid solution. So this is an important phase that many will be in for quite a length of time. You still have enterprise content management, ECM. Now you've moved to that. That's a bigger piece. You're moving into EMR. You have an integration really through a medical records portal. So this may be a portal provided by one of the EMR areas. What we're finding in our research is that the portal technology of the EMR providers is not as strong as the independent portal capabilities that might be provided from an IBM or an Oracle. So the larger organizations tend to build a EMR independent portal capability for this, and also for external access, for billing and for patient records. So they can sort of combine that technology infrastructure for that. But in other cases, the point is that your primary view into content is really through this portal that's providing a sort of a pseudo integration, if you will, to these various still siloed information repositories. So there's still limited EMR and DICOM integration. EMR is evolving, but there's still a strong dependence on unstructured content. For content features, less dependence on physical charts, that's great. Using a lot of sort of sophisticated capture capabilities, auto ID with barcodes and OCR for image capture. So when you scan in patient records in paper, you can use the extraction capability and actually insert pointers into the EMR that will get you to that electronic folder that's in that unstructured environment, in that ECM environment, but at least you're getting that sort of pseudo integration. So you start to bring in records management, basic forms automation and workflow for some processes. And we'll take a look at some of those, the top ones from our research. Stronger interoperability, but still pretty limited. So when you look at the guidance, workflow automation, you're now in a position to look at provider workflows, start prioritizing workflows for automation. You can start to eliminate static forms wherever possible. You can start to really look at these emerging capture capabilities for auto ID. You really start to leverage that point of care, access and entry of information. And you're at a point of applying barcode technology to image capture to do that linkage with EMR. So these are some of the tips to move to the next phase. One of the areas in this phase that's important is going to be case management. Now, case management has a very particular definition within healthcare. If your insurance company will, appoint one. If you have something that may be an extended care situation, there's a case manager, at the hospital facility. So case management has had a long-term interest in the healthcare area. But what we're seeing now is the notion of case management across all industries is gaining, a lot of traction. So, what is it? It's really a semi-structured, collaborative, dynamic, information-intensive process driven by outside events. I think that's the key, the outside events that drive it. and there's incremental and progressive responses that accumulate in the case. So the case is really the electronic folder, if you will, that's accumulating this content, in a way. When you look at what's different about case management now and the next generation of case management in medical, it will combine these elements on the slide. So, you have that enterprise content management suite to be able to manage that unstructured content, for the life cycle of the case. So that's document management, records management, customer community, all the things we're talking about. But you're also going to have analytics, so you want to be able to, assess what went well with that case, be able to look at data across cases. You want to have strong analysis and reporting around that case, and there's a big emphasis on analytics right now, in the medical environment. So that's something that is really new to, I think, the case management as it's typically been understood in medical. There's also a lot going on with social technologies, with instant messaging and with collaboration sites. The case management has to have the ability to leverage those social technologies to be able to get the kind of collaboration in a team environment and a team care environment. Very, very powerful when you start to apply those emerging technologies to cases in the medical area. And of course, BPM. It's really that intersection of ECM and BPM that makes case different. There's rules related to how to handle a case. Those should be in some sort of rules capability. You have steps and checklists in a case that can be automated. It's really having a template that has the steps in it managed by the BPM system that is really important for case management. So you're going to be seeing a lot of development, a lot of interest in case management in the medical environment. These are everything that might be included in a case. You have people aspects. You have data, from the EMR. You have the process I talked about with BPM. Policies are in there. If you have a change in a legislative event that you want those policies changed to be a external rules capability, so that they can be easily separated and auditable. That's an important thing. Reporting, collaboration, again, those social technologies. This is what the modern case is going to look like. Now, so you have case management. You have a phase 2 that starts to bring in automation technologies. Where do we focus? So you see in the middle of this diagram the provider's core, more strategic systems. That's EHR should really be EMR. We use EMR to be the provider's medical record system. You have compliance systems, clinical systems. You have your PAC systems. But around that are these untamed processes that we talked about. And some of them are very content-centric. Some are just abandoned in the sense that there's no provider, that the EMR provider just doesn't find that to be a strategic area yet. So they're not able to provide that bedside e-signature process. That's important. You have social services automation that may be considered outside of the spectrum of capabilities that the EHR provides. Incident reporting, which is a case management app where an incident comes in and you want to have a resolution of that. You want to see who made the decisions. You want to have the analytics to see how incidents can be handled better in that. All the outpatient self-assessment workflow, preoperative workflows, so you don't have static forms being signed in each of the departments. You can do that all electronically. These are areas that are being prioritized in the providers that we spoke to who are at that phase 2 level. Now, on the administrative side, there's also a lot of challenges. Probably the strongest area here would be that RAC workflow. This is the audit capability that is being required by the government for Medicare payments. So it's a sort of a mini Sarbanes-Oxley event in that all providers need to be prepared. And again, that's a perfect case management application of the RAC. Request comes in for audit, a case is set up, all the content related to that is set up, the response to it is a template in that case environment that is similar to the way you want to handle it, that you can agree to. So it's not this ad hoc, we've never done it before. It's an actual case management application around the RAC requirements. So this is just a sense of the major workflows on the administrative side that we're seeing. Now, phase 3 is really about collaborative and interoperable patient record. This is where we want to go. Now, you see the EMR bubble is big because at this point there's been a strong transition to EMR in the provider base. The EMR is the role-based and collaborative access. By role-based, we mean that if you're a nurse, if you're a physician, if you're a social worker assigned to a case, the information that you need will be presented in a way that you can consume it. There's integration with clinical and data repositories to get the analytics that we talked about for results-based medicine. Now you have a cross-provider workflow where the EHR, which is the record that goes across the provider areas, different providers, is now available. So you're able to integrate with health information exchanges. So you have an interoperable patient record at this point. Fully functional EMR for all areas, and you have mobile telemedicine, right? So if you have doctors, the top wireless apps for physicians that we surveyed tended to be patient monitoring, so that you can keep folks in their homes longer, have monitoring capabilities set up. But number 2 was access to patient records. So while there's issues with the ergonomics of the devices in terms of real estate for looking at the patient record, that is something, allowing the physicians to work remotely and the whole care team is very important. And of course you have that because you're interacting through that EMR portal capability and getting wireless access to that. Now there are organizations that are close to phase 3 now, but no one's completely there, mostly due to the cross-provider record and the interoperability associated with the patient record, not really there. Okay, so that's just a glimpse at the future, and in the interest of time, let me talk about some guidance for phase 3, and let me just talk about some of the major trends we're going to be seeing. Evaluate whether the patient's charge could benefit from advances in collaboration and social technologies. It'll sound crazy, but I think Facebook, obviously not having something as public as Facebook, but having a concept of a community of caregivers focusing on a patient and having them interact in that collaborative environment is ultimately the way the patient record will go. So at some point, we'll figure out that what's working on the consumer side for collaboration actually has an application within the medical treatment area. Prepare for that interoperable patient record. That is going to happen. It's going to be a requirement. Prepare clinical systems to present EHR in machine-readable format so that you can provide that interoperable record. You can hand a patient a record that they can take with them and have that be absorbed via XML into another environment. Look at emerging standards. There's really a problem with standards in medical because of the variety, the looseness of the taxonomy. You can have a particular event and have 400 different ways to tag it in a system. That's unlike financial services where there's much more agreement over the years because they've had to do wire transfers and funds transfers. So, medical has a particular issue with regard to standards, but they are very important. This area of e-discovery and records management is going to be very, very big in medical. The ability to absorb content for a litigation and not use outside attorneys to save costs, to have an e-discovery system with, as part of your information management is a trend we're going to be seeing. Obviously, records management control is key to having compliant medical management of information. So if you look at the emerging trends, these are just some of the areas that we think are going to be very important. Workflows to support consumer-driven medical access. That's going to drive a lot of new systems and new investment. BPM, as we've talked about, centers of competency, cross boundaries. Compliance and RAC audit, case management being a framework that'll be placed in. Alternate delivery models. So By that we mean, open source applications for EMR, SaaS applications for EMR, particularly for physician practices. So SaaS is software as a service. You don't have to install anything on premise. You're on a click charge model. We're going to see the way to get those some 90% of physicians outside of hospital networks into the medical record environment to get to meaningful use is really to provide low-cost SaaS offerings that can do that. We talked about wireless apps. This increased focus on analytics. Analytics is driving a lot of industries right now in terms of information management, and it's going to be particularly important as the medical community turns that boat towards not procedure-based billing, but results-based billing. So analytics is going to be absolutely critical. So with that, I think I've gotten through my time, and I'm going to turn it over to Scott Fuller at this point, and hopefully we'll have some good Q&A at the end of this. Thank you very much for your time.
Thank you, Craig. I'm going to talk a little bit first about Formfast, just to give some brief background on the company, and then I want to get into our high-performance hospital concept. First, who is Formfast? We are the leading provider of automation technologies to hospitals in the United States. We have well over 800 customers that include large and small hospitals and IDNs. We work with all major HIM systems, and in particular we're the vendor of choice for Meditech and McKesson in their solutions. We're privately held in St. Louis, and we've been in business since 1992. Our mission, simply stated, is to provide automation solutions that support hospitals in their mission by automating manual paper-based processes, increasing patient safety, reducing data errors, lowering operational costs, and enabling the next generation of healthcare information. Let's talk a little bit about the high-performance hospital. Really what this is what we consider a workflow-driven hospital, sort of stepping back, taking a look at your hospital in terms of workflows and looking for the manual processes that are being done that perhaps don't always adhere to hospital policy, that also are costly in both hard dollar costs as well as soft dollar costs, where this absorbs a lot of FTEs in these processes. When you examine these manual workflows and look to automate them, you can gain some tremendous efficiencies as well as some other byproducts. We have a little model here kind of talking about going from 0 to 100. The pinnacle and where we strive our hospital partners to be at is at the pinnacle here, being a high-performance hospital. You start out at the very basic service offerings that do kind of address your pre-printed forms, eliminate a great deal of costs, as well as some other logistic issues with getting forms updated and of that nature. The next step in the pyramid is print on demand, and that's making your forms electronic, making them available for nursing floors to print the forms that they need when they need them, not relying on other departments to get them. And also, too, this is a huge cost savings. The next step is actually taking these forms and making them smart documents, linking the forms to the data that already exists within the HIS system or really any database that's available in the hospital. Just keying in a few identifiers and let the form just automatically populate, saving a lot of data errors and even some processes that require checking. This does just a tremendous job at that. And then the peak, the pinnacle, is workflow. This is what I'm going to spend the majority of my brief time on, is just talking about the workflow piece. This is actually taking those documents, the smart documents that you may be having filled out automatically, and routing them through the hospital to automate the workflows that you perhaps currently are doing manually. Some things that, in my experience, working at a hospital, I found automated workflows to do. They're tremendous barrier breakers. The enhanced communication between departments. A lot of times think it applies here. You have every department kind of doing their own thing, and information and certainly forms or any kind of processes that go between departments, sometimes the communication suffers in that. Automating a workflow is just a tremendous barrier breaker to that. And that, as the second point says, it kind of creates a single sheet of music that everybody plays off of. And that just, in turn enhances the communication. Another kind of byproduct of an automated workflow is it ensures the policies are followed. When you're creating a workflow, an automated workflow, and you're setting up the rules and the roles that different people play, you're actually modeling that after whatever policy that you want the workflow to follow. And when the workflow is initiated, there isn't any room or latitude for changes or doing it another way or doing go-arounds. You can actually control that. And it really does help to ensure that policies get followed. And just on a very simple basis, automated workflows enable departments to interact better at the day-to-day workload level. I'm just going to go over 10 interdepartmental workflow examples. These all sort of reside in the revenue cycle support services area, which in my experience is a very kind of a rich field of opportunity within a hospital. There's a lot of focus on EMR right now, but as Craig mentioned, there are just a lot of other parts to the hospital that EMR doesn't address. And I think as a former IT director, one of my big responsibilities, while implementing an EMR was also I had to keep the ship sailing, and I couldn't just ignore the rest of the hospital while we're implementing an EMR, as tempting as that might be at some times. The first workflow, and again, these are just different uses that I have found for FastFlow and what I was able to do. Some are big revenue savers. Others were just sort of eliminated little pet peeves. This first one sort of falls into that category. We had issues when people wanted to move offices. The coding manager decides to move someone to another room or against another wall. They get environmental services to move the person. After they're there and they're set up, or not quite set up, they call IT and ask, well, please come in and set up the telephone and the computer. IT shows up, and there's no electricity on the wall. There's no network jack, all these things.
Craig, I hate to interrupt you, but we're getting a couple messages that it's a little tough to hear you. Do you mind speaking up just a bit for us? Thank you.
Sure. I hope this is better.
Yes, that's definitely better. Thank you.
All right, thank you. I'd very much like to, I'll just kind of finish off with this one. If there's anything that anybody missed, please during question and answer period, I'll be glad to go back and elaborate on anything. Again, with the office move, it created a workflow that allows a department to just initiate a request that gets filled out. It automatically routes over to engineering. Engineering gets a chance to go look at the area. Is it an appropriate place to put an employee? Do we have electricity there? Is there going to be costs associated with that? And then once engineering is done with the form, it automatically routes over to IT. IT goes out and takes a look to make sure there's a network drop. Is there capabilities of plugging in a phone, that type of thing. And then it routes back to the department, advising them of any costs and the possibilities. Once they approve it, then it flows over to EVS. There are certainly ticketing systems that in use in hospitals, but they don't particularly conduct a workflow in between departments. Engineering may work off of a ticketing system, but the ticketing system doesn't allow for other departments to have input on this. Another example, and this one, our hospital, we had purchased Kronos. We purchased everything that Kronos offered to a hospital, from nurse staff scheduling, HR, benefits, workforce timekeeper. Just a terrific package, certainly not a mark against them. However, upon implementation, we quickly discovered there was really no way a director had of terminating an employee or transferring an employee from department to department. Certainly, if you had access to the HR module, you could go in there and do, kind of start a process. But as the directors, not everybody has access, and there was no workflow. And Kronos kind of relied on that process to be done external. Now, historically, our hospital, we had paper form for it. Personnel action request was the title of it. It kind of goes by different titles at different organizations. We took that routing and we sort of enhanced it. A director fills out the form electronically, submits it. It automatically goes for administrative approval. Once it goes to administrative approval, a couple things happen. And this is the advantage of an automated workflow versus manual workflow. It immediately splits out. HR gets notified. At the same time, payroll gets notified. The workflow also spawns emails to both the IT department and security, informing them of the status change. Certainly, IT doesn't need all the personnel information that may be on the rest of the form, so just advising them with an email at that step that employee such and such had this status change, say termination at such and such date. It allowed for a lot of processes to happen simultaneously and much more efficiently. And it certainly kind of filled in a very large gap that we had when we implemented Kronos. Another one, this can be done several different ways, and the process is different in the hospital, but basically it's anytime you have a price or cost change in the CDM, the different departments that need to be aware of that, charge entry, administration, business office, sometimes it even needs to communicate to insurance companies, depending on what their particular contract allows with the hospital system. Accounting may need to know because if they do any kind of cost reporting or projections, that's certainly things, and of course, materials management. Purchases, purchase requests. Certainly an ordering department initiates it. It travels, after approval into materials management, and these rules can be set up to handle it automatically. If the person ordering is a director and the director has up to, say, a $500 limit without approval, the form can be intelligent enough to realize that the total of what's being requested is $500. It'll skip administrative approval and go straight to materials management if that's how you choose to design it. However, if it's a $10,000 purchase, it will follow another path. However, it's defined is very flexible, and it allowed us to just completely automate that process, as well as speed things up. Another big advantage of these workflows, from an ordering department, you fill out a PO on paper and you send it off interoffice mail to the next person in the step. You really don't know where it's at. And sometimes when you're in a hurry for something, you don't know who to call, where it might be stalled. Within a fast flow workflow, you can go in and you can actually see the status of where it's at, and you can even set the workflow to where if it stalls at a particular step for any length of time, it can send notifications back to the originator. And a lot of times it's very reassuring when you're trying to purchase something in a hurry. You can see where it's at. You can pick up the phone, push somebody to, please look at their work queue and move things along. Another interesting workflow is new product evaluations. This is where the hospital gets presented with a vendor some product. Maybe it's a new PIC line that it's cheaper, it's better. At least that's what the vendor says. The hospital wants to consider it. Well, there's a workflow associated with that. The clinical people need to look at the product and comment on whether or not it truly is better, if it meets the standards for the hospital, if it enhances the quality of patient care. Accounting will want to look at it and just take a really good look at the costing advantages and create an ROI, all along attaching this information to the workflow. And then finally, it kind of comes in for administrative approval, where, upon approval, then it circles back to generally a purchasing department for for them to take action and actually start ordering the new product. Another area is insurance audits, and for us, this was built basically on top of our RAC audit system, which was completely built in Formfast. And insurance audits tend to be much simpler in flow than a RAC audit, but they have a lot of the same steps. A claim is rejected for whatever reason. It perhaps didn't meet medical necessity for an inpatient. That's the challenge. Well, now you need to hold a medical record, have several people taking a look at it, route it back to coding, make sure, if coding is interpreting things correctly, maybe even get, nursing and physicians back involved in the process to actually see if it truly did meet medical necessity. The RAC audit is basically the same type of flow. It's just much larger in scope, and RAC audits tend to have a little more time pressure because from the time you're notified of the audit, you have 45 days to prove yourself, or basically the Medicare contractor comes in and just takes it away from you. So it's a little bit more pressuresome. And to be able to put these into a workflow. And another nice thing I'd like to add here, too, is that in development of this product, Formfast has a really nice dashboard that allows you to just look at sort of an administrative level and say, okay, of all the audits I have in, which ones are stalling and which ones are on track. And they're all color-coded and ranked. So you have a really good sense of where you're at, if things are bogged down or if everything's moving very smoothly. And that was something, again, as a former IT director, that I found lacking in many other audit products, was the ability to, automate the workflow and then still allow someone in the organization to sort of stay on top of everything. Because when you're talking about, millions of dollars of potential claims being challenged, it really warrants a lot of very careful care. Another example of biomed equipment breakdown, again, sort of mimicking a ticketing system, but an initiating department can just initiate a workflow form. It automatically routes through biomed engineering. Sometimes, depending on the device, if it's a rental device versus something that was purchased, materials management would need to get involved to either order parts or to typically materials management had the relationship with the rental vendors and access to the necessary contracts to see what was allowable for replacement. This workflow would significantly cut the time it would take for a piece of equipment that became faulty to get either replaced or repaired. And it was a very popular workflow with clinicians. A check request, a little bit different than a PO. If I need a check for whatever reason, we have to request it of accounting. There's usually some sort of approval, again, depending on dollar amount. Very easy workflow. Just pull up the form, fill it out very quickly. If there was some piece of supporting documentation, it could very easily be scanned and attached to the workflow. And so when it went through the chain of approval at every step, they would have all the supporting documentation. And again, as a person requesting the check, at any moment I could see at whose inbox, whose work queue was it sitting in. So if this was something that perhaps I was in a hurry for, I had the luxury of being able to follow it along and see, who I needed to call and bug to kind of push things through. The next one, peer review reporting. Certainly there are systems for this. However, we're able to actually mimic this in this power tool that we bought, FastFlow. Basically, peer review and reporting just involves initiating department. Typically, a nurse see something that's of concern in one of our colleagues, needs to get reported, and compliance, risk management, and depending on severity of it, administration needs to get involved. Very similar to the next and last workflow I have listed here, incident reporting. Incident reporting, and this can be any incident in the hospital, and it needs to be reported. They need to be tracked. The information, will touch, certainly risk management, safety, administration, and possibly even the legal departments of the hospital. And the workflows and the rules associated with this can be very well defined. It also can be ad hoc. For this particular workflow, we sort of let everything flow into risk management. Risk management would read all the detail, sometimes requesting additional detail, and then decide whether safety needs to get involved, if legal needs to be involved, or if this is more of a compliance issue. It allows for what's considered ad hoc routing, where you can send it to where you need to go. Again, these 10 examples I just ran through are just sort of part of what you can do. Really fast flow. What I found out is it's a power tool that I was able to do many different things and sort of fill in a lot of gaps and cracks in the processes. And when I stepped back and looked at my hospital in terms of workflows and what we were doing, it just really allowed me to automate several of these processes and, again, strive to make, my old organization a high-performance hospital. At this time, I want to pass control, I believe, back over to Laura, and we can, answer some more questions. Thank you.
Sounds great. Thank you very much, Scott. I appreciate that. Craig, we have a question for you. During the course of your research, did you find information about the utility and acceptance of mobile devices for physicians, in particular for assisting with documentation and point-of-care information?
Yeah, so there were sort of two things that came out of that. One, reports by a few CIOs that had implemented mobile devices with very mediocre success. So that's, mobile access can be from, the laptop at home, but can also be from a mobile device. So mobile devices, while being a sort of nice toy excitement for a little while, ended up not having the real estate on it to really make it functional for physicians. But the mobility was important in two areas. On the administrative side, it was being able to use off-site coders to do some of the administrative work, the linkage between the clinical and the administrative systems. So that was able to, once you got the content into a workflow, into electronic form, then the mobility really helped in being able to reduce the cost of coding. And secondly, the ability to keep that physician from having to come into the hospital via having wireless access to medical records and medical information was the second highest, mobile application that we found in our research, number one being patient monitoring.
Great. Thank you very much for that information. And the last question is also for you, Craig, on how long until the majority of providers are at phase 3?
Boy, if I knew the answer to that question, that would be terrific. I think what the research showed was that there was a real diversity in the path that organizations are going to take. And there's a huge difference between the large-scale integrated service delivery environments and, your relatively small community teaching hospital. So you really have to look at it in terms of a segmentation like that. I think that the larger environments are going to be at phase 3, probably within 3 years. Some of them will be in phase 3 with 3 years. I think it's going to be a decade for, the segments below that that are not, really don't have the resources to invest in the technology needed to get there.
Great. And one last question came in. How difficult is it to implement the clinical part of EMR before the administrative part, and why is it recommended to initiate admin first?
Well, I've puzzled with that myself. Obviously the admin side, and of course, when you look at things like PCOE that have been sort of really well accepted, they have implications for both sides. It's easier for the doctor to order, and then all your downstream administrative is tracked and billed and so forth. I have heard that a way to gain adoption for EMR is to have that implemented so that the doctors can see that the real valuable information is actually in this system. And once they sort of have that attitudinal shift, they then it's very easy to migrate them to other electronic aspects of the systems, of all systems. So to me, there's a really strong benefit to for the long term in implementing on the physician side, provider side, but the ROI for the systems has to be based on administrative efficiencies that have to do with revenue cycle. So the main, technology provider sales argument has to do around, reduction in revenue cycle issues. So when you base it on that, then you're likely to, start with more on the administrative side. But I think it's actually a toss-up, or I would even lean towards, providing the enhancements in care and the changing the overall attitude of physicians towards use of electronic versus paper.
Great, thank you. We do have a few more minutes if anybody else would like to ask a question. I wanted to address the point of this presentation will be made available. I just need you to email us with a request for a copy of the presentation, and you can reach us at www.formfast.com. Go to the Contact Us page and then fill out the request for information. We will also post a recording on our website within the next week. Okay, it looks like there are no other questions at this time, so I'd like to take this moment to say thank you very much again to Craig and Scott today for such terrific information. And again, if you do have any further questions you'd like to contact us, please call us at 1-800-218-3512. And again, we appreciate your time. We know that it's valuable, and we'd like to thank you for taking the last hour to learn more about EMR, the EMR journey, and the high-performance hospital. Thank you very much, and have a great day.